Hello, everyone. Welcome back to Luncheon with the Experts, the Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I'm a documentary filmmaker and a writer that has been working with CCF for over 10 years. And in that 10-year span, we have created all kinds of video series, live video series, Q&A sessions like what you're going to see today, documentary-based, patient-centric stories, treatment-based videos, all kinds of videos, but all with the same mission in mind, and that is to spread education and raise awareness about neuroendocrine tumors. So if you are new to the show and new to this journey, I want to say welcome, and I encourage you to reach out, introduce yourself like the people are doing in the comments, tell us where you're signing on from in the world. The value of this show I really see is twofold. One, the information you're going to get from our guest presenter and answers to your question. And two, the community, the shared stories and shared experiences from the people in the community. This community is extremely supportive, extremely strong, so I can't encourage you enough to embrace them. They will embrace you back. Before we get started, we always want to thank our sponsors, Ipsen Biopharmaceuticals, because without their support, we couldn't do the show. And we always have this disclaimer from them, and that is that the opinions expressed by the guest presenter today, as well as the questions asked by you all, the audience at home, haven't been created or suggested by the sponsors of Luncheon with the Experts. And CCF doesn't necessarily endorse or promote any of the views, opinions, or information provided in the presentation. So audience members should not rely solely on that opinions or those opinions and information expressed by the guest today, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. So that last line is really the takeaway. We don't know your specific case, or our guest doesn't know your specific case. So we're going to give you some good general advice, some good answers to your question, but take that advice and those answers back to your home team, which does, and make the best plan and path forward for you. Because one thing that I've learned for certain over the past 10 years is that each case of this disease is unique, and therefore each plan and path forward is as well. Today, I'm very excited to welcome back to the show Dr. Joseph Dillon. How are you, Dr. Dillon?
Well, thanks, Rain. Good to see you again.
Absolutely. For those that might have missed you on the show last time, tell us a little bit about what you do, where you work, and the role that you fill in this NET community.
Sure. So I work in Iowa City, University of Iowa, where I'm currently the director of the Neuroendocrine Tumor Clinic, a role that I took over from the late Tom Odorizio a couple of years ago. Like Tom Odorizio, I'm an endocrinologist by training, but for the last 10 years or so, or more at this stage, I've been treating solely patients with neuroendocrine tumor, carcinoid tumor. We've got a big group here at Iowa in that neuroendocrine tumor group. So some of the questions that might come up today, I might say I'm going to defer that to some colleagues, but happy to take questions.
Absolutely. And the team there at the University of Iowa is very impressive, folks. I've got to spend some time with them, and definitely want to send some love to the late Dr. Odorizio that Dr. Dillon mentioned. Friend of the foundation, a friend of the show, a guest on the show, a friend of mine, very, very great soul, and a legend in this space. So we always appreciate him and the work that he did and just the person that he was. So always want to send love to him. Doc Odo, as he was affectionately referred to by a lot of his patients. So folks, here's how the show is going to go today.
Right.
We have already some questions coming in. Go ahead and send in your questions, but a little bit of tips for you to formulate your questions in a better way that allow me to get them asked and answered. So, i.e. to help you. Try not to just pack 4 or 5 questions into 5 paragraphs and long questions. Short little bites, generically asked, because again, we can't really get too case specific today. And if you have follow-up questions, or you have other questions, which I know you do, send that in a separate question a little bit later in the show. So ask them in general terms to help you get from the state you are now, or the stage you are now, to the next step, and then ask that next question instead of trying to like dump all the information about your specific case into the question, which doesn't necessarily help us get those questions answered. But you are certainly welcome, if you're still in the show, to ask follow-up questions, Just give me a little bit of context. If it's in reference to a previous question you asked, give me a little bit of context to remind me, because I see hundreds of questions and comments. That will really help me if you just say, hey, I had the question about ... and then ask your follow-up question. If you know someone that should be here and could benefit from this interactive one-on-one session, go ahead and tag them in the comments. We got great numbers already, and we're not even 10 minutes in. We want to get as many people here as possible, but if they miss it, or if you want to rewatch it, it will be posted immediately onto Facebook, and it will be evergreen, and it'll stay there permanently. And starting Monday of next week, we will repost it to YouTube, so you can always rewatch these programs later. Before I start taking questions, I want to give a special shout out to Grace Goldstein, the COO of the foundation, who you may have seen has officially announced her retirement this past week. She has been with the foundation for 19 years. I've worked with her for 11 or 12 of those, and she is a force. She has completely dedicated herself to this foundation and this community, and she is inspiring, and I am grateful for the time that I've had to work with her. So she's always behind the scenes here on Luncheon with the Experts. So if you want to send her some love, send her a little heart emoji and say, thank you, Grace, in the comments. I know that I thank her every day for the opportunities she has given me. So first question, Dr. Dillon, that comes from Dorothy is, my neighbor just had surgery for an endocrine tumor. I have a neuroendocrine tumor. What exactly is the difference?
Sure. So an endocrinology is the study of glands that make hormones. We have many glands that make hormones: our pituitary gland, our thyroid gland in the neck, parathyroid gland in the neck, adrenal glands, testes, ovaries. They all make different hormones. So they're all endocrine glands. So your neighbor could have had perhaps a thyroid surgery. That's an endocrine surgery. Neuroendocrine is a sort of a subgroup of endocrine glands. They actually, unlike the endocrine glands that I just mentioned, which are pieces of tissue in various locations, like the thyroid is an inch or two of tissue in your neck. The neuroendocrine glands or neuroendocrine cells are individual cells spotted throughout your body. There's some of them in the thyroid, there's some of them in the lung, there's some of them these are naturally occurring in the stomach and the intestine. So they're pretty much all over your body. Now, a person could get a neuroendocrine tumor as a tumor growing in one of those cells, which becomes a neuroendocrine or a carcinoid tumor or a pancreatic neuroendocrine tumor. There's even another layer of complexity that another sort of subgroup of neuroendocrine tumors also go by the term pheochromocytoma and paraganglioma. These tend to be in the adrenal gland or just to one side or other of the spinal column. Again, small pieces of tissue that can become tumors and that can make hormones. Endocrine glands make hormones. Neuroendocrine glands make hormones. Neuroendocrine tumors can make hormones and chemicals. Hope that's some explanation.
Absolutely. Yeah, I appreciate your question. And folks, this goes for anybody. This is kind of a blanket statement. If I didn't quite get your question right, or if there's another piece of it that we missed, always chime back in. Okay, we're here for an hour, and we're here to answer your questions. That's our job. Thanks, Dorothy. Next roll from Rebecca, which I like this question because I really like to lay the groundwork before we get started. Sometimes we jump right into the dense, very nuanced questions, and that's fine. We're here to answer those questions. But Rebecca says, what role does the endocrinologist play in our treatment? I love that to start us off.
Sure. So in the group of neuroendocrine tumors, there are about 30% of them, 30 to 40% of them, where there's a clear production of hormones. These are called functional tumors. If those tumors start in the pancreas, they may be producing insulin causing low blood sugar, glucagon, high blood sugar, and the variety of other hormones causing symptoms. In the tumors that neuroendocrine or carcinoid tumors that start in say the lung, or particularly the intestine, they produce the carcinoid syndrome, characterized by flushing and diarrhea particularly. So those hormonal manifestations are some things that endocrinologists are trained to recognize. Also, the main first step, or perhaps the first step after surgery for many people is a hormonal therapy. It's the use of either octreotide or lanreotide injections. Those are artificial forms of the hormone somatostatin. And somatostatin then inhibits both the further production of hormones by the tumors, but it also, perhaps more importantly, inhibits the growth of these tumors. So both the diagnosis of neuroendocrine tumors has endocrinology aspects, and the treatment of neuroendocrine tumors has endocrinology aspects. I think that there are many people who need to be involved to make the best therapy group for your neuroendocrine tumor. Apart from you advocating for yourself, you need a medical oncologist there. There needs to be a surgical oncologist who's focused on treatment of neuroendocrine tumors. Nuclear medicine specialists who are focused there. Gastroenterologists, many of the symptoms of neuroendocrine tumors are gastrointestinal, and it really helps to have a gastroenterologist. So while I don't feel that an endocrinologist needs to be the leader of the team, happens to be so at Iowa, but doesn't need to be. But they're a very helpful component of the team.
Got it. Thanks. That's a great overview. And Rebecca, I appreciate your question. Let me know if there are other questions you have. A quick statement from Roger. This will be a terrific presentation. Dr. Dillon is a premier, caring, world-renowned NET specialist and also an extraordinary person.
The check is in the mail, Roger.
Roger, I couldn't agree more, my friend. And I think we're already off to a great start for our terrific presentation today. No pressure, Dr. Dillon, no pressure. Okay, from Rita, I hope I'm pronouncing that correctly. What can I do if there are symptoms of CS, carcinoid syndrome, and serotonin of blood mild elevation, but I can't have contrast because of CKD?
Right. So an important issue. There are so the situation here is that when people have damage to their kidneys from whatever reason, there are many medications that they can't have. There are it's preferred that they don't have intravenous contrast with a CT scan. Mm-hmm. So there are many different scans that we can use to look for neuroendocrine tumors. CT scan, usually with contrast, is perhaps the workhorse scan. CT of the abdomen for abdominal or pancreatic, CT of the chest for lung neuroendocrine tumors. However, MRI of the abdomen is a great scan for looking at, certainly for pancreas and liver, and an MRI of the lower abdomen can be performed as well. So MRI contrast is not specifically contraindicated. It can be given in people with damaged kidneys, depending on the level of damage. And then in many situations like this, where I have patients who have known neuroendocrine tumors who I'm following and can't, for whatever reason, use those scans, the PET imaging scans, where the agent is a radioactive form of octreotide or lanreotide that I mentioned previously. So those PET imaging scans, sometimes called DOTA PET scans or net spot scans or copper or gallium. They have various names associated with them, but another great scan that will pick up most neuroendocrine tumors. So there are alternatives to CT scan. In lung neuroendocrine tumors, I would depending on what I'm looking for, I would also consider a non-contrast CT scan in the lung to look for nodules. It's quite a reasonable scan there.
Got it. Thank you very much. And Rita, thanks for your question. Next question from Christy. What does a high chromium level mean? And is it dangerous or is it just indicative?
So I wonder, is Christy talking about a high chromogranin level rather than a chromium level?
Possibly.
Chromium is an element in the environment and in our diet, and it's a trace element. I don't usually end up measuring chromium levels, but we certainly measure chromogranin A levels. So chromogranin A is one of the many hormones or chemicals that can be made by neuroendocrine tumors. So many neuroendocrine tumors will, in patients' bloodstream, the neuroendocrine tumors or the carcinoid tumors will produce chromogranin A, and increasing chromogranin A level would be a sign that perhaps that tumor is growing and becoming more active, and that we should be looking at it with different scans if we're not seeing growth, or B, we should be initiating new or different treatment. However, chromogranin A is also, I think, one of the more complicated neuroendocrine tumor blood markers to measure, because chromogranin A is very sensitive to certain medications which are very common, such as the medication group called PPI, which are acid-lowering medications, omeprazole, Prilosec, pantoprazole, those sort of medications to lower stomach acid will increase chromogranin A in everybody, irrespective of whether they have a neuroendocrine tumor or not. Also, perhaps to go back to Rita's question with the CKD, people with chronic kidney disease or chronic heart failure will have high levels of chromogranin A. So chromogranin A needs to be very much interpreted in the context of all of the other medical conditions, any changes in medication that have occurred. But it can be a useful marker of increasing tumor activity and tumor size.
Got it. Thank you. Appreciate your question. Next one. I appreciate that, Christy. Next one comes from Jennifer. Is there a difference in response to Lutathera for rhesus negative blood types?
Wow, what an interesting question. I have never seen that question addressed. I'm going to have to pass on that one. I can't think of I'm just thinking theoretically, and PRRT, of course, is again a radioactive form of somatostatin, which, when injected into the bloodstream, circulates around the bloodstream and attaches itself to areas of tumor, attaches itself to a docking site on the tumor called a somatostatin receptor. Now, that interaction and that irradiates the tumor. Of course, that interaction, I can't see why that interaction should have anything to do with the blood group, blood types. It's I don't think of somatostatin receptors as being associated with red blood cells. There are some on white blood cells. So I'm not sure for definite, but I can't think of a reason why it would be. But I must look into it. now that you've
Yeah,
raised it.
absolutely. That's definitely the first time I've gotten a question like that too. And Jennifer, if there's follow-up questions that you have, of course, please send those along too. We appreciate you being here. From Stephanie, any truth in weekly B12 injections feeding active tumors? And there's a few other people that have this this question as well.
So, so vitamin B12, a very important vitamin for low B12 can be associated with anemia, can be associated with nerve damage, can be associated with feeling very tired, and vitamin B12 deficiency is a fairly common and perhaps not looked for often enough factor in patients with neuroendocrine tumors of the small bowel, which of course are the most common neuroendocrine tumors, after those people have had partial bowel resections, because the part of the bowel that gets removed tends to be the part of the bowel that is most efficient at absorbing vitamin B12. So many people then need vitamin B12 supplements, either by mouth or sometimes, if their B12 is low enough, by injection. So now specifically the question though is whether enhancing vitamin B12 levels can cause tumors to grow. And again, a little like the rhesus question, I have never seen any evidence that neuroendocrine tumors, carcinoid tumors, even pheochromocytomas have any sensitivity to vitamin B12, and that vitamin B12 would help them grow. So my answer is a qualified no on that one. Again, something I need to go back to the literature and see if somebody somewhere has done some, laboratory experiments perhaps to show an effect of vitamin B12. But I have a lot of patients on vitamin B12, either by mouth or indeed by injection, and I've never considered that to be harmful. I've considered that to be a benefit.
Got it. Well, thanks, Stephanie. Hopefully that helps, folks. We if you joined us a little bit late or just joined us recently, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program. We are here with what one guest has promised would be a terrific presentation with Dr. Joseph Dillon from the University of Iowa. And we're moving along, folks. It's almost halfway past the hour already. It's going by quickly. But I wanted to make a point about Stephanie's question and something you all did that I'd failed to mention at the beginning of the program, which I typically do, but it looks like my regulars to the show understand it anyway. A few people liked that question, and that's how I knew that there was, more of a demand, or other people had that question. So if you see a question in the comments section that you also have, or you're interested in the answer to, just under the comment, it says like, reply. You can like it, love it, any of the emotions that Facebook allows you to use. They all work the same way for me, and that is to effectively upvote that question. If I see 8 people have the same question as I'm going through them, I'm going to make sure to get that one across. So just helps me understand which questions. All the questions are important, but we never can get to them all just because we get so many. That's why we have the show every week. So if I know 8 people have this question and I can, help 8 people in one answer, that's the choice I'm going to make that time. So appreciate that. Thank you very much. I just saw a mad emoji. What was that for? Ruth says, would neuroendocrine cancer in the omentum be considered gastrointestinal cancer?
So neuroendocrine cancer does not start in the omentum. Neuroendocrine cancer spreads to the omentum. The omentum is, as a non-surgeon, I think of the omentum as a sort of saran wrap-like covering of the intestines, and I'm sure my surgical colleagues will be groaning. So when neuroendocrine tumor is in the omentum, it is a metastatic tumor. It has come from somewhere, and the single most likely place that a tumor will come from to get to the omentum is the small bowel. is bowel, is gastrointestinal in general. The neuroendocrine tumor in the omentum is probably a secondary gastrointestinal neuroendocrine tumor from a primary tumor, which is probably in the small bowel.
Got it. Thank you. And thanks for your question, Ruth. Next question from Beth. Is Mycapssa approved, and is it an alternative to daily octreotide injections?
So Mycapssa is an FDA-approved medication. It is an FDA-approved. Mycapssa, for those who don't know, there's a lot of excitement about the possibility of moving those monthly injections that people get, or indeed daily injections that people take, of octreotide or monthly lanreotide, making oral formulations of those. And it's a difficult job technically because these chemicals get degraded very easily in stomach acid. So Mycapssa then is an oral, a by-mouth tablet that has been, to my knowledge, FDA approved for the treatment of acromegaly, instead of the use of monthly sandostatin, octreotide, lanreotide. Now, to my knowledge, also, it has not yet been FDA approved, and I'm not even sure where they're at in terms of clinical trials with Mycapssa and carcinoid tumors. So there's a history of how these type of drugs, these somatostatin-like drugs, come to market. Going back to when octreotide and sandostatin started, they were initially, and lanreotide, they were initially tested and got FDA approval for acromegaly, a growth hormone-producing pituitary tumor. It is not as aggressive a tumor as carcinoid tumor. It does not tend to be malignant. It does not tend to spread out to other places. So it's a little less of a dangerous situation than metastatic carcinoid tumor. So drug companies get the FDA approval there first, and get more experience with the compound, and then try to roll it out into carcinoid tumors. So bottom line, I don't think Mycapssa has an FDA approval for neuroendocrine tumors. Somatostatin analogs like octreotide, sandostatin, lanreotide are so important in terms of inhibiting tumor growth that I would not suggest taking Mycapssa off-label instead of a monthly medication. I just don't think that is a wise thing to do before it's thoroughly tested. Mycapssa is one of the first of the tablet formulations. There will be other tablet formulations of that type of medication. So very exciting area for research. It would be great for our patients not to have that pain in the butt every month. But I don't think it's there yet. And I think you have to be careful about jumping to that just because it's there for another disorder.
Got it. Thank you very much. And thanks for your question, Beth. Next question from Greg. What is the probability for ALT blood levels to increase with liver metastasis?
So, the usual blood tests that people will be used to seeing on their usual liver panel will be alkaline phosphatase, ALP, and then ALT and AST. One of the problems about, and there are also some other liver blood tests, bilirubin, albumin. One of the problems with that liver panel in general is that a person needs 60 to 70% of liver being taken over by tumor before those will be consistently elevated. So it's not a great. It's a poor manifestation of ongoing tumor growth, at least in the earlier stages. Now, those enzymes, ALT, AST, ALP, may be up after certain forms of treatment, such as embolization treatment, where the physician blocks off blood vessels to tumors in the liver, or ablation treatments where liver tumors are basically, a probe is inserted in a liver tumor and it's microwaved or it's burnt from the outside. That will cause a big and transient increase in those liver blood tests. But in general, they're not very sensitive. So likelihood, Greg, is relatively low until very late.
Got it. Thanks, Greg. Dr. Dillon, this next question is a little bit case specific, but there's a few people that have it. So I'm going to ask it and we'll just see if you can field it. So Miranda says, grade 2, stage 4, 6-centimeter primary in the appendix, lymph node and peritoneal involvement. 20-year-old dotatate PET scan and CT did not show any tumor in the liver in June. When she was 20 years old. Pardon me. So the PET scan and the CT did not show any tumor in the liver in June, but recent MRI shows tumor. The report says favors hepatic adenoma over metastasis. The question is, how do they confirm it is not cancer? And a few other people were interested in this. So that's
right. So my understanding is that there was an appendix tumor. It had already metastasized into lymph nodes.
Correct.
There was a recent PET scan just last month, which was negative. Now, the vast majority of appendix tumors, I would say 95% of appendix tumors have what we call somatostatin receptors. They have docking sites on the surface such that if we give a radioactive form of somatostatin, it will stick to those areas. And when they do a PET scan, they inject a person with radioactive somatostatin. I'm assuming now that the appendix is out, the lymph nodes are out, and the PET scan did not show anything at all. So if there were tumors in the liver, we would, if there were neuroendocrine tumors that had come from that appendix in the liver, we would expect them also to have the ability to stick to somatostatin, to stick to that radioactive substance that's given during the PET scan, and the PET scan would light up in the liver. And the PET scan can light out, can see things or show things that are down to, perhaps 5 millimeters, even 4 millimeters in the liver, if they've got those receptors. So now, very shortly after June, we have an MRI scan that is showing some lump in the liver that was not seen on the PET scan. So that lump in the liver does not have those neuroendocrine tumor features for a start, which makes it very unlikely that it has come from the original appendix. Number two, there are, and at this stage, I'd be deferring to some of my radiology colleagues, because the radiologist, there are features that radiologists will use to differentiate the different nodules and lumps and cysts that are in the liver. So how well the intravenous contrast, how quickly the intravenous contrast goes into that nodule, how quickly it comes out of that nodule, what it looks like on all of the various different types of images that can be done, and the radiologists, particularly using MRI and different MRI contrasts, can give a very good and very a generally correct opinion on what the nodule is. Now, if you had an appendix tumor and you had lymph nodes, you've had previous CT scans, so they've also been able to compare that MRI with the previous CT scans. So in summary, then, because the PET scan was negative, and most likely it should have been positive with an appendix tumor, I think it's most unlikely to be a neuroendocrine tumor. Number two, there are specific features on the MRI that a radiologist could explain to you, and if you look at the fine print of what's in the MRI report, they'll talk about how it enhances and how it is on this image and that image and the other image. And these all mean a lot to our radiologists. They don't mean a lot to me, but the radiologist can come up with a bottom line that is fairly certain about the type of nodule that's in the liver.
Got it. Thank you. And thanks for your question. Next question from Sarah. Hi, I was wondering if you have seen neuroendocrine tumors on the skin, and if so, how to treat them.
So there are neuroendocrine tumors on the skin. I don't tend to see them. So let me qualify that. So there are primary neuroendocrine tumors that start on the skin. They tend to be seen by dermatologists initially, and they tend indeed to be treated by dermatologists or medical oncologists. They do that. They tend to be treated by those people because the neuroendocrine tumor that starts on the skin is quite an aggressive neuroendocrine tumor. It also does not respond, in general, it does not have those receptors for somatostatin. It does not respond to monthly injections. It does not respond to radioactive somatostatin, the PRRT that was mentioned before. So it's an area that I don't tend to get involved in and don't know a lot about. There have been a few years ago, there were some very nice articles showing that these tumors, primary neuroendocrine tumors on the skin, unlike most neuroendocrine tumors in the abdomen and chest, can respond very well to some of the newer immunological agents, and there was very exciting work that came out on that. Now, the other part of that question is neuroendocrine tumors can go to the skin. So it can be a site of metastasis of a lung neuroendocrine tumor, can have a bump on the skin with a neuroendocrine tumor that's derived from that lung neuroendocrine tumor. And similarly, bowel neuroendocrine tumors can go to the skin. It's a very unusual place for neuroendocrine tumors to go. They tend to go lymph nodes, liver, perhaps bone, and then some other sites that are more unusual, and skin is of the more unusual type. In that situation, however, the secondary neuroendocrine tumor may very well have somatostatin receptors, may very well respond to monthly injections, to PRRT, may very well light up on PET imaging. So two slightly different neuroendocrine tumors, the ones that start there and the ones that go there.
Got it. Thank you. Moving along, next question from Rose. I was recently diagnosed with malignant hypertension that was caused by the injection treatments of octreotide, lanreotide, and sandostatin. Why does this inhibitory hormone therapy cause the sudden rise of blood pressure?
Gosh, Rose, that's a very interesting side effect of these agents, and I would have to hear a little more about that to tease it out. It is, you know, I've treated thousands of people with these agents and have not come across a diagnosis of malignant hypertension being caused by these agents. It is indeed, you know, hard for me to even think through the possibilities there about why, you know, as you so well put it, how an agent that's supposed to stop hormones and chemicals being produced can produce hypertension of that degree. I'd have to look at that situation more carefully, and I'm drawing a blank on that one. I will, along with the rhesus and the B12, I will have to look more into whether there are other people who've had such problems. It's a new one to me after using a lot of these medications.
And folks, back to my initial point about the community that we have helped cultivate here, and at least at the show and in the comment section talking, this is a good opportunity. If other people have experienced similar things, share that. I mean, it's not just a one-way information, going one way from our presenter or from our guest today. So yeah, chime in if you've experienced that. We're going to keep taking questions. We've got about 15 minutes left. So moving along, Donna says, what, if any, tests do you favor rather for monitoring serotonin level? Blood test, 5-HIAA, 24 urine test, 24-hour urine test. What is a reliable and necessary method? And several people have this question as well.
Right. So historically, the test that's been used since 1960s, 1970s, something like that, was the 24-hour urine collection for HIAA, and HIAA is the breakdown product that comes out in the urine from the breakdown of serotonin in the bloodstream. So 24-hour urine HIAA, there is a huge amount of experience with it, and experience with understanding, what level of 24-hour urine HIAA would give what sort of symptoms, and but 24-hour urine HIAA is also a difficult test to do appropriately, because because urine HIAA is very dependent on diet, dietary sources of serotonin, dietary sources. So there's so you will get a diet that will have you not taking certain fruits and vegetables, nuts for at least 3 days before you collect it. So it's a bit of a pain to do it. We have at our clinic, we've moved on to blood serotonin levels, and blood serotonin levels early on were very problematic, because without the proper chemical storage agents in the blood tube, the serotonin would break down, or the serotonin would change, and so the testing was not very good. We find that whole blood serotonin levels are very consistent from time to time. Others find more consistency in a blood HIAA level. So previously we were only able to measure the urine HIAA. There is an amount of HIAA that occurs in blood, and many people find that to be a less variable test than blood serotonin levels. So we measure whole blood serotonin. I certainly measure plasma HIAA, and I'll certainly look at people's testing of 24-hour urine HIAA. I think one of the critical things with all of these blood tests is getting it measured the same way each time, getting it sent to the same lab each time. So there are differences amongst the reference laboratories in how they measure blood serotonin. There's only, I think, one or perhaps two places in the country measuring blood HIAA. There are more places measuring urine HIAA. So the importance is that the lab that it gets sent out to needs to be the same lab each time, so that we're comparing apples with apples, because measuring serotonin in one lab one time and another lab another time there will be huge degrees of variability there. Very frustrating for everybody.
Got it. Thank you. From Donald, does extensive liver metastasis result in liver disease, cirrhosis?
So extensive liver metastasis certainly can decrease liver function, particularly after that degree of liver metastasis gets in the 60% of the liver, 60-70% of the liver. It affects it can cause decreased liver function. There are a number of the treatments that we give for neuroendocrine tumors, and particularly neuroendocrine tumors in the liver, that may promote the sort of damage that causes what we call cirrhosis. So cirrhosis is a condition, and again, I'm not a hepatologist, so my concept of cirrhosis is that cirrhosis is a hardening of the liver due to fibrosis of the liver. It becomes harder, fibrotic, less live liver cells doing what liver cells are supposed to, which is cleaning out toxins and making proteins. So cirrhosis can be caused by many different conditions. Alcohol can cause cirrhosis, hepatitis can cause cirrhosis, and radiation can cause fibrosis of the liver, which I guess could be called cirrhosis in some terminology. So one of the treatments for liver tumors then is radioactive liver embolization, so sometimes called TheraSphere or SIR-Sphere, where a physician will put a cannula, an intravenous, an intra-arterial tube into the artery in the liver and push in small, fine granules which are radioactive, which both block off the blood supply to the tumor and are also irradiate the tumor. Well, they happen to irradiate normal liver as well, and if that's been done repeatedly, can cause some fibrosis of the liver. PRRT, again, while it's very much focused, it very much attaches to the tumors. It does have a small area of normal liver that it irradiates, which could cause fibrosis of the liver. So it's more, I think, the treatment over the years of those liver tumors that can cause fibrosis of the liver, which then, of course, worsens the liver function.
Got it. From our friend Michael, is weight loss a thing with NETs in your experience?
So is it a thing? So does weight loss occur? So let me take that a couple of different ways. Does weight loss occur, commonly as a component of NETs, and maybe in the run up to the diagnosis of NETs? Patients can be diagnosed with neuroendocrine tumor with a couple of different scenarios. It can be just an accidental diagnosis. Person gets involved in a motor vehicle accident, has a CT scan, boom, there's something in their abdomen, never knew about it.
Right.
But people can come in because that lump in their bowel is blocking their bowel and causing them to feel full more easily, feel nauseated, get abdominal pain, so they stop eating as much and they're losing weight. So in that way, weight loss going along with the bowel blocking effect of a neuroendocrine tumor. Also, people might be diagnosed with a neuroendocrine tumor because of the carcinoid syndrome. So multiple diarrhea, you're losing huge amounts of nutrients in your stool, you're losing huge amounts of liquid as well, and weight loss can be a component based on that as well. And indeed, there are some other, perhaps more unusual neuroendocrine tumors, pancreatic neuroendocrine tumors that make glucagon. Weight loss and decreased muscle mass is a component of that. So weight loss can be a component. I wouldn't say it's a particularly common component of the presentation that people tell me about. I think weight loss is a more common component in my mind for patients who would be attending medical oncology clinics for carcinomas, carcinoma, the other non-neuroendocrine tumors. Weight loss can be a component of people who have the neuroendocrine tumor called pheochromocytoma, because they've got so much adrenaline running that it raises their body temperature, the metabolism rate, so they're just burning through calories very quickly. So there are some aspects where weight loss is a component.
Got it. Thank you, Michael. From Jessica, hi all, Dr. Dillon, how common are stomach NETs as a primary site? If the local lymph nodes are showing on the dotatate scan, is this considered metastasis? And what might be a plan? Oh, I just lost that question. Let's just take the first part of that question.
Okay, so how common were stomach carcinoids, and sort of B, if they're in local lymph nodes, is that metastatic? So neuroendocrine tumors or carcinoid tumors, as a generality, do not start in lymph nodes. So anything that's in lymph nodes is a secondary cancer, a secondary tumor, a secondary carcinoid, a metastasis, in other words. So those have come from somewhere and are metastatic. Gastric carcinoid. So gastric carcinoid is a relatively rare cause of metastatic neuroendocrine tumor, but it's a very common finding as a sort of a more mild finding. And let me just explain that. So people who take drugs like omeprazole for a very long time, cuts down stomach acid, or people who just don't have stomach acid because they have chronic inflammation in their stomach, those people generate small carcinoid nodules all the time, either microscopic nodules or very small nodules, and when they have endoscopies, the endoscopist will find very small nodules that need to be removed every couple of years. In general, those nodules don't ever get big enough to spread out. They don't generally, as long as somebody is looking down there and picking them off every couple of years, they don't generally cause a problem. But there are more rare ones than which are unrelated to stomach acid, where they can grow bigger and spread out into lymph nodes. But that's considered a relatively rare site for those more serious carcinoids.
Got it. Thank you. And kind of a follow-up to that, Jim has a question regarding stomach nets as a primary. How frequently is metastasis to the stomach?
Metastasis to the stomach from some other site, say a small intestine or pancreas. So metastasis to the stomach, and I may or may not know Jim. Metastasis to the stomach, if I do know Jim, let me repeat for Jim, metastasis to the stomach is really rare. You know, I have seen it a few times, but it is a really rare phenomenon. Again, the sites for metastasis tend to be lymph nodes, liver, bone, sometimes lung, sometimes brain, a couple of other sites occasionally, but stomach is a very rare one, and it's super rare to have it, you know, in the absence of lots of other secondary tumors in lots of other places.
Got it. Well, thanks, Jim. I think we have time for one more question. We've had a ton of questions today, everybody. From Eileen, would prednisone stimulate net growth?
No, I do not think of prednisone as stimulating net growth. Prednisone can do certain things to nets. One of the things it can do is alter the number of receptors for somatostatin on the tumors, and thus decrease the number of somatostatin receptors on the tumors, and thus possibly decrease the effectiveness of the monthly injections or PRRT. Now, so when we have patients who we're giving PRRT to, who for whatever reason we want to give prednisone to, we tend to give that prednisone after the PRRT has gotten in there for 12 hours or 24 hours, so to give the PRRT a time to get on those receptors before doing anything. But I do not think of prednisone as a causative for stimulating growth of nets.
Got it. Thank you, folks. That is our hour. That is our show. Jennifer says, where does Dr. Dillon work? He works at the University of Iowa. And folks, listen, we had a ton of questions today, and I know that many of those did not get answered. And so I want to reiterate, if you have follow-up questions, you can reach out to Carcinoid Cancer Foundation, either here on the Facebook page where you are, just send them a private message, or that website right behind me, carcinoid.org, and we will get you the questions. But also, some of them are really great and not that could be asked any week depending on the specialist. So I encourage you, this is really the fuel for the show, is your questions. We need you all here. Come back next week. That's why we're able to have the show every week, and we want to get these questions asked. So there are many good questions today. Don't get discouraged. Keep coming back to the show and do your due diligence. You know, reach out to CCF and they'll take care of you. Dr. Dillon, thank you so much for being here again today. I appreciate you sharing your time and knowledge.
Thank you, Rain. Thanks for the opportunity.
Absolutely.
And thanks to all of you listening.
Yes, thanks to all of you listening as well. As always, we hope this program helped answer some of your questions. I see a lot of comments coming in that it did, so that's great to see. That's what we love to see. Please, and again, reach out to CCF if you have other questions. Thanks as always to our presenting sponsor, Ipsen Biopharmaceuticals. We couldn't do the show without them. And finally, my name is Raymond Bennett. I have been your host. Thank you for watching, and please join us next week on Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye-bye.